Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 362 of our pharmacotherapy series, which majors in chronic obstructive pulmonary disease. The next case reads, JOK, a 46-year-old woman with a 32-pack-year history of cigarette smoking, presents with increasing shortness of breath. She gets winded walking on level ground after about 100 yards. She quit smoking 2 years ago. The chronic cough that she previously had lessened after smoking cessation, but the dyspnea is now somewhat worse, despite use of an albuterol inhaler on an as-needed basis. On examination, mild wheezing is noted. A chest X-ray is unremarkable. Office spirometry demonstrates an forced expiratory volume in 1 second to forced vital capacity ratio of 0.64 and an absolute forced expiratory volume in 1 second of 2.0 liters or 60% of predicted. JOK has a CAT score of 20. And has had 1 exacerbation in the past year, which was managed at home. Post-bronchodilator treatment demonstrated a forced expiratory volume in 1 second increase of 100 milliliters, a 5% increase. So my question to you reads, how should JOK be treated? JOK would be considered to be in Group B. She has had progression of dyspnea despite smoking cessation and the addition of a short-acting beta-2 agonist. She is still at a low risk for an exacerbation based on her exacerbation history. Because pharmacologic management of chronic obstructive pulmonary disease involves a stepwise approach, regular use of a long-acting bronchodilator would be the next step in treatment. The main classes of long-acting bronchodilators currently available include beta-2 agonists and anticholinergics. Both classes can be further divided into 2 groups according to duration of activity: those producing bronchodilation for 12+ hours and those producing bronchodilation for 24+ hours. Both classes have been shown to improve quality of life and reduce dyspnea in patients with chronic obstructive pulmonary disease. Next we will discuss long-acting beta-2 agonists. The role of inhaled, long-acting beta-2 agonists in the chronic management of chronic obstructive pulmonary disease has become well established in recent years. Available evidence with both salmeterol and formoterol shows improved pulmonary function, reduced dyspnea, and enhanced quality of life in patients with chronic obstructive pulmonary disease. Indacaterol, olodaterol, and vilanterol are dosed once daily and have a rapid onset of activity, e.g., greater than 5 minutes, and produce bronchodilation for 24 hours or more. Their long duration of activity and comparable safety profile may offer an added convenience to some patients. A plateau in bronchodilation is achieved for most patients at the recommended dose for each agent, so no benefits exist in exceeding the recommended dose. In addition, higher doses will increase the risk of adverse events associated with beta-2 agonist excess. Therefore, salmeterol should be prescribed as 42 micrograms, 50 micrograms in a dry powder device, twice daily, and formoterol at 12 micrograms twice daily. Next we will discuss the long-acting anticholinergics. Vagal cholinergic tone is a reversible component of the airway limitation in chronic obstructive pulmonary disease. Stimulation of the vagal parasympathetic nerves causes the release of acetylcholine, which then binds to muscarinic receptors to produce bronchoconstriction and secretion of mucus. 3 muscarinic subtypes have been identified in human airways: the M1, M2, and M3 receptors. Tiotropium is a long-acting anticholinergic that binds to the M1, M2, and M3 muscarinic receptors of bronchial smooth muscle. Although tiotropium dissociates rapidly from the M2 receptor, it dissociates much more slowly from the M1 and M3 receptors. In fact, its dissociation from the M1 and M3 receptors is 100 times slower than that of ipratropium. M1 receptors are located on parasympathetic ganglia, where they facilitate postganglionic transmission, thus enhancing cholinergic tone. M3 receptors are found on airway smooth muscle and mucus glands, where activation leads to bronchoconstriction and mucus secretion. Conversely, M2 receptors are located on postganglionic nerve endings, where they serve as autoreceptors regulating acetylcholine release and, thereby, cholinergic tone. Thus, anticholinergics, by virtue of antagonizing M1 and M3 receptors, relax airway smooth muscle, and can reduce mucus secretion. M2 blockade, however, augments acetylcholine release and thus enhances cholinergic tone. Therefore, the slower dissociation rate from both the M1 and M3 receptors enhances bronchodilation and allows the convenience of once-daily dosing. Tiotropium has a very long duration of action and can provide effective bronchodilation with once-daily dosing. Numerous studies have documented its beneficial effect on pulmonary function and quality of life. The UPLIFT, an abbreviation for Understanding Potential Long-Term Impacts on Function with Tiotropium, compared 4 years of therapy with either tiotropium or placebo in nearly 6,000 patients with chronic obstructive pulmonary disease. Tiotropium was associated with improvements in lung function, quality of life, and exacerbation risk, but did not impact the rate of decline of forced expiratory volume in 1 second or mortality. Tiotropium is also a quaternary amine with limited systemic absorption. Therefore, the agent is well tolerated, with dry mouth being the major side effect. Concerns have been raised, however, about tiotropium's safety. In particular, disparate sources have identified stroke, cardiovascular events, and death as possible adverse outcomes. After completion of UPLIFT, which included 17,721 patient years of drug exposure, the FDA recently concluded that the appropriate use of tiotropium in chronic obstructive pulmonary disease patients does not place them at increased risk for stroke or adverse cardiovascular events. In September 2014, tiotropium was also approved to be delivered via the Respimat device. The tiotropium safety and performance in Respimat, abbreviated as TIOSPIR, trial is the largest chronic obstructive pulmonary disease trial to date involving more than 17,000 patients. This trial was designed to directly compare the safety of tiotropium Respimat to tiotropium delivered via the handy HALA device. The length of time to first chronic obstructive pulmonary disease exacerbation was also followed to compare efficacy. Both the Respimat and HandiHaler were found to have comparable results for exacerbation frequency, as well as exacerbations associated with hospitalization. The incidence of adverse events was also similar between all treatment groups. Aclidinium bromide, marketed as Tudorza Press Air, umeclidinium bromide, marketed as Incruza, and glycopyrrolate, marketed as Seabri Neohaler, are long-acting anticholinergics recently approved for the long-term maintenance treatment of chronic obstructive pulmonary disease. These agents have been shown to improve lung function and appear to be well tolerated. JOK should be started on a long-acting bronchodilator, such as salmeterol, formoterol, or tiotropium. Once-daily beta agonists such as indacaterol or olodaterol are additional options to consider. Recently approved anticholingics such as aclidinium bromide, glycopyrrolate, or umeclidinium bromide are other potential options. It should be noted that the tolerability and efficacy of the available long-acting bronchodilators are comparable. The choice of agent is largely based on considerations such as the frequency of drug administration, the patient's ability to use the inhalation device correctly, and any out-of-pocket costs incurred by the patient. JOK should also be instructed to continue her albuterol 2 puffs every 4 hours as needed. A 3-month follow-up visit should be scheduled to assess her response. JOK is started on tiotropium Respimat, inhale 5 micrograms daily and returns to the office for a checkup in 3 months as recommended. She has had significant benefit from the medication and has had decreased wheezing and a noticeable improvement in her exercise tolerance. She asks to have spirometry repeated to see whether her lung function has improved on the new medication. Spirometry is repeated, and no significant improvement is noted in her forced expiratory volume in 1 second. She asks how she can feel better, with improved exercise tolerance, without an improvement in her lung function. Increasing evidence suggests that bronchodilators, including long-acting beta-2 agonists and anticholinergics, may reduce exercise-related dyspnea in patients with chronic obstructive pulmonary disease by decreasing dynamic hyperinflation. This improvement may be independent of marked changes in spirometry performed at rest. Indeed, because of flow limitation, these patients who exercise can have significant worsening of air trapping, which can worsen lung compliance and adversely affect respiratory muscle mechanics. A number of studies have shown that alleviation of such dynamic hyperinflation may be an important mechanism whereby bronchodilators improve exercise tolerance in patients with obstructive lung disease. JOK seemed to do reasonably well for a number of years. But now, 3 years later, she has noticed progressive dyspnea on exertion. She is now having difficulty carrying laundry up from her basement, and she has noticed that her overall activity level has been curtailed. Repeat office spirometry now shows a forced expiratory volume in 1 second to forced vital capacity ratio of 0.49 and an absolute forced expiratory volume in 1 second of 49% of predicted. She now has a CAT score of 22, and has had 2 exacerbations in the past year. JOK has been adherent with her tiotropium regimen and has had no other significant changes to her medical history. She remains smoke-free and is not exposed to second-hand smoke in her home and work environments. So my question to you reads, what therapeutic intervention or interventions should be considered at this point? We will now discuss inhaled corticosteroid therapy. JOK has had significant deterioration in status and repeated chronic obstructive pulmonary disease exacerbations despite appropriate adherence to tiotropium. Patients with findings consistent with chronic obstructive pulmonary disease risk group D should be prescribed combination therapy consisting of either an inhaled corticosteroid plus long-acting inhaled beta-2 agonist or long-acting muscarinic antagonist plus long-acting inhaled beta-2 agonist. Fixed-dose combination products are preferred and several options are commercially available. Long-acting muscarinic antagonist plus long-acting inhaled beta-2 agonist therapy may be preferred given the lower incidence of pneumonia and adverse effects related to inhaled corticosteroids. One long-acting muscarinic antagonist plus long-acting inhaled beta-2 agonist combination was superior to inhaled corticosteroid plus long-acting inhaled beta-2 agonist in preventing exacerbations and other patient-reported outcomes in those with a history of prior exacerbations. However, a number of multi-center, randomized, controlled clinical trials have demonstrated the efficacy of inhaled corticosteroid in chronic obstructive pulmonary disease. The data have supported the use of inhaled corticosteroid in advanced chronic obstructive pulmonary disease and in patients with frequent exacerbations. Regular use of inhaled corticosteroid can decrease the frequency of acute exacerbations and improve health-related quality of life in patients with a forced expiratory volume in 1 second less than 60% predicted. The TORCH study has defined the benefits and potential side effects of inhaled corticosteroid in a broader patient population of chronic obstructive pulmonary disease. In this multi-center, randomized, placebo-controlled study, mean forced expiratory volume in 1 second was 50% predicted, but entry criteria did not require a history of repeated exacerbations. More than 6,000 patients were randomly assigned to either an inhaled corticosteroid, fluticasone 500 micrograms twice daily, inhaled salmeterol, 50 micrograms twice daily, combination fluticasone 500 micrograms and salmeterol 50 micrograms twice daily, or placebo. Subjects were assessed for approximately 3 years. A significant benefit was seen as measured by decreased exacerbation rates in subjects taking either inhaled fluticasone or a combination of fluticasone-salmeterol therapy. Also, an improvement was found in mortality with combination therapy that approached, but did not reach statistical significance. Overall adverse side effects with inhaled corticosteroid were similar to those with placebo. An increased risk, however, was seen for lower respiratory tract infections with inhaled fluticasone or fluticasone-salmeterol. Of note, patients did not experience an increased risk of ocular manifestations or decreased bone density with inhaled corticosteroid treatment. JOK is already taking tiotropium, so a decision must be made regarding step-up therapy. A long-acting muscarinic antagonist plus long-acting beta-2 agonists is the preferred regimen for this patient given findings consistent with chronic obstructive pulmonary disease group D. Tiotropium should be replaced with tiotropium plus olodaterol fixed-dose combination product. JOK is already familiar with the Respimat device, which may help maintain adherence. However, other long-acting bronchodilator combination products exist. A number of other potential interventions may be considered. One option would be to discontinue the tiotropium and initiate a combination inhaled corticosteroid long-acting beta-2 agonist. Alternatively, an inhaled corticosteroid long-acting beta-2 agonist product may be added to the tiotropium given the severity of her disease. Lastly, an inhaled corticosteroid could be added to the tiotropium, although less evidence is available to support this option. Any of these choices is reasonable provided no other major contraindications in doing so exist. It should be noted that currently several corticosteroid long-acting beta-2 agonist inhalers are indicated for chronic obstructive pulmonary disease, including Advair, that is fluticasone salmeterol, Symbicort, budesonide formoterol, and Breo Ellipta, that is fluticasone vilanterol. No convincing data suggest that one preparation is superior to the other in the treatment of chronic obstructive pulmonary disease. The exact duration of treatment that inhaled corticosteroid should be given before making an assessment of their benefit is not clear. Generally, an adequate trial is at least 4 to 6 weeks. One rationale for the use of inhaled corticosteroid in chronic obstructive pulmonary disease is, however, the prevention of acute exacerbations. As such, it can be very difficult to measure objectively the clinical benefit of the medication in individual patients. JOK calls the next day, having read something on the internet regarding possible increased risk of death in people with obstructive lung disease who take long-acting bronchodilators. She is reluctant to take it. So my question to you reads, what should you tell her? Although some evidence in asthma indicates that use of long-acting bronchodilators may be associated with an increased risk of death, such evidence does not exist in patients with chronic obstructive pulmonary disease. In fact, the TORCH study demonstrated no increased risk of death or adverse events among patients prescribed salmeterol compared with placebo. The patient should be reassured that long-acting bronchodilators are safe in chronic obstructive pulmonary disease. JOK also wonders whether anything else other than her medication can be done for her. So my question to you reads, what advice might be given? At this point, pulmonary rehabilitation should be strongly considered. In fact, a comprehensive multidisciplinary pulmonary rehabilitation program should be considered in any patient with chronic obstructive pulmonary disease experiencing persistent shortness of breath despite pharmacologic management. Increasing evidence points to chronic obstructive pulmonary disease as a systemic process, and pulmonary rehabilitation addresses the systemic nature of the disease. Although the proximate cause of disability involves the respiratory system, leading to dyspnea on exertion, this in turn has systemic consequences. Although the changes may be fairly subtle to start with, most patients will gradually manifest increasing limitations in their activity. This results in substantial deconditioning. It is likely that this deconditioning, in addition to other factors such as systemic inflammation, adversely affects skeletal muscle function. Indeed, evidence is clear that oxidative capacity is diminished in patients with chronic obstructive pulmonary disease, which results in overall decreased aerobic capacity and results in increased lactic acid production for a given level of activity. The increased acid load will lead to a greater requirement for ventilation, which makes dyspnea more severe. The more dyspneic the patient is, the less activity he or she will do, leading to more deconditioning and recapitulation of the downward spiral. Pulmonary rehabilitation is an exercise-based, multidisciplinary program that seeks to address this cycle. Most programs generally last 8 to 12 weeks and involve 2 to 3 sessions per week. Education, particularly about medication use, as well as psychosocial counseling and breathing retraining, are important components of the program. An important component of breathing retraining involves coaching patients how to use pursed lip breathing effectively. Pursed lip breathing involves pursing the lips together, as in whistling, during exhalation. This helps to slow down respirations and also provides a back pressure in the small airways, preventing dynamic airway collapse and exercise-induced hyperinflation. The major intervention, however, is exercise training, especially endurance training of the lower extremities, e.g., using a treadmill or bicycle ergometer. Numerous studies have demonstrated that a rehabilitation program can significantly improve exercise capacity and quality of life, as well as decrease healthcare utilization. This may partly be related to the beneficial effects of exercise on the oxidative capacity of the skeletal muscles. JOK should be referred to a local outpatient pulmonary rehabilitation program. A typical program involves 2-hour sessions, 3 times per week for 10 weeks. The sessions will involve education, breathing retraining, and strength and endurance exercise training. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 363.